Okay, we are live now. Okay, best of luck, Dr. Munera. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله. We are delighted to welcome you today for our lecture by Dr. Munera. She is our colleague, consultant oncology in Prince Sultan Medical Military City. I welcome also Dr. Suhail Mamtari, the consultant thoracic surgeon in Prince Sultan Medical Military City. I hope all you enjoy the talk. We will have lecture done, then we'll open the questions and answer. For our participant, please kindly write down your questions, and we will look at it at the end of the lecture. Dr. Munera will answer, Dr. Suhail also can answer and comment, and I hope you enjoy the lecture. Dr. Munera, please go ahead. Good luck.
بسم الله الرحمن الرحيم. Thank you, Dr. Suhail, for sharing the presentation as a modulator, and Dr. Zaidi for organizing. Stage 3 lung cancer has been chosen because of having lots of challenges and not reaching a consensus on the appropriate approach in different settings. It's as we said, it consists of a heterogeneous group based on the extent of the disease, the location, and the controversy on treatment approach has been ongoing for decades. The earlier clinical trial, one of the reasons for having no consensus so far is because of the small number, because it consists of a small portion of patients amongst lung cancer. It only consists around 20 to 25% in trials. The earlier clinical trials have also not been powered and for survival, not randomized. Usually it's the phase 2 single arm and with short follow-up. Also, there has been lots of improvements in the surgical techniques, reducing morbidity, and the radiation methodology, reducing toxicity at the long term, especially cardiac toxicity, with more active chemo agents that has been introduced, like Pemetrix and platinums. The definition of stage 3 disease has also been changing over time, and therefore the slides I'm going to present have used ASCO and ASTRA guidelines basically to establish recommendations. As we said, that the stage 3 disease definition has been changing and across the with time, and it has been different comparing earlier to later clinical trials. Here are examples and differences between the 7th and 8th edition of the TNM staging system. The primary tumor and the 7th edition, the T4 disease is a primary tumor extension to extrapulmonary structures. The mediastinal lymph nodes are only in 2 and 3, are diagnosed are staged in 2 and 3. The T3 lower cutoff is 70 centimeters, exceeding more than 7 centimeters with no lymph node involvement keeps the patient at stage 2B disease. While in the 8th edition, 5 centimeter cutoff was used for T3 disease, and and the combination with hilar upper bronchial lymph node involvement gives stage 3A is a T3 in 1, giving stage 3A disease. And exceeding 7 centimeter in diameter for the tumor is a T4 and 0, giving a stage 3B disease. So definitely there is a difference between the 7th and the 8th edition, and those have been used in earlier trials. And the latest years we have introduced 8th edition in inclusion criteria. So a mediastinal evaluation is an important cornerstone in determining the management approach. It aims for pathological confirmation of the enlarged CT or metabolically active PET lymph nodes at PET scan. To determine the resectability of the tumor. And whenever we have negative lymph nodes, that's a stage 1, stage 2 disease, the tumor is considered resectable. The mediastinoscopy with good improvement in survival. The mediastinoscopy and endoscopic bronchial ultrasound have been used primarily for the mediastinal evaluation. If we have a negative results, further mediastinal assessment is recommended during surgery. If we have positive results, we need to discuss the definite chemotherapy is the standard approach, but there is, as we have going to see in subsequent slides, there is a subset of patients that can benefit from surgery, which needs to be discussed in tumor board setting. There is still controversy amongst the need in T1A tumors, whether that are located in the periphery, whether mediastinal staging is required or not, if we have no suspicion for N1 or N2-3 disease. So here is a treatment approach in general of if we have no enlarged lymph nodes or peripheral tumor, we can proceed, and lymph nodes may not be exploration will not be required, and surgery is recommended. If we had an unforeseen lymph node into disease, we may consider adjuvant chemotherapy. The presence of enlarged, if the tumor is central with higher lymph nodes, enlarged discrete lymph nodes, that's N0, N1, N2, or N3 disease. We identify the patient as N0, N1, N2, or N3 disease. N2 are considered potentially resectable in certain settings, as we're going to see later, while N3 disease is definitely not resectable and should go for concurrent chemoradiation. We will discuss in for more details based on the staging, the surgical rule in different settings. The T3 for T3N1 disease, this is a stage 3A. It's generally considered operable for if the patient had an ipsilateral nodule in the same lobe, that's considered a T3 disease. Here is also the patient considered operable. However, if he had an ipsilateral nodule in a different lobe, but in the ipsilateral lung, that's considered a T4 disease, and this case needs to go to the tumor board to discuss resectability based on the size, location, and mediastinal staging. If the surgery is not feasible, you may offer the patient stereotactic radiosurgery or conventional radiotherapy. Adjuvant chemotherapy in this setting is recommended, but it is extrapolating from stage 3 disease and other settings, but limited evidence is but this is not well represented scenario in clinical trials, and therefore we consider it of limited evidence. The LACE collaborative group have examined the benefit of adjuvant chemotherapy in different stages of lung cancer. They pulled, it's a pooled analysis from 5 large trials, including 4,584 patients. All the regimens have been used in these trials were cisplatin based. And the survival benefit have been demonstrated basically in stage 2 and 3 disease with hazard ratio of 0.83. The absolute benefit at 5-year survival is 5.4%. The efficacy of addition of adjuvant chemotherapy has been seen with all regimens, regardless of the combination agent with cisplatin. Now, if we had a contralateral lung nodule, and the if we have seen on an imaging nodule in the contralateral lung, that's a special scenario that requires further attention. The by TNM staging, it's considered a metastatic disease, but there are some theories that it could be, and in some cases that has proven to be asynchronous primary. And therefore, the patients may undergo staging workup and metastatic evaluation. If those were negative, we can treat the patient as having a synchronous primary. It has been shown that this approach can associate with favorable outcome, suggested by a long-term survival of 67 months, 3-year overall survivor approaching 64%. That has been based on Memorial Sloan Kettering follow-up data for 175 patients, including different stages of lung cancer at baseline and the ipsilateral tumor. Sorry, in the initial so T4N1N0. This is also considered a stage 3B disease, but it's considered to be difficult to operate because of the difficulty achieving our resection. It's rare representation. It's a rare presentation, and it's not well represented in clinical trials. So we don't have randomized data to provide statistical proof of the survival benefit for patients who are undergoing extended resection. Also, there is a subset that could be involving superior vena cava of T4N1 or N0 that could be involving superior vena cava or tail with pulmonary vessels. The 5-year survival from complete resection in these settings has ranged in different series between 9 and 48%. It also needs to be discussed in a tumor board for possibility of neoadjuvant chemo, preoperative chemoradiation, if the feasibility for complete resection was not possible. There was no feasibility for resection. We can offer the patient neoadjuvant chemo and preoperative chemoradiation because of because of the overall response rates that could approach 59%, with 80 to 85% of patients achieving good resectability in stage 3A and 3B disease in earlier clinical trials. So we agree that stage 1 and stage 2 should be offered surgery, but if during surgery and the patient had metastatic evaluation and the pathology changed to stage 3, that could happen. What shall we do in this case? That could happen in 20% of cases, and it's anticipated in central large tumor lesions. The patient should be offered adjuvant chemotherapy because of the survival benefit that we have seen earlier. In the LACE collaborative group analysis. The adjuvant chemotherapy regimen should be including the platinum, the adjuvant radiation therapy, the platinum doublet. The adjuvant radiation therapy is only approved for positive margins. There is no rule for targeted therapy. Actually, the trial of gefitinib in adjuvant setting has shown inferior survival compared to standard supportive care. There are also the addition of cetuximab and adjuvant setting in the ARTIG 0167 trial has shown no benefit. But there are ongoing trials to use other agents, including adjuvant nivolumab. The adjuvant chemotherapy, as we said, should be offered to all stage 2 and 3 based on the pool analysis data from different trials, and that could be discussed for stage 1B. That's considered, but we should also consider the pre-existing comorbidity and recovery from surgery if that was a difficult situation to offer adjuvant chemotherapy. The Wakil Tal and his colleagues and published in ASCO 2000 and represented in ASCO 2016 and the Lancet Oncology 2018 publication showing a comparison between different platinum-based regimens, showing no difference in no difference in survival, even if you stratify the patients based on histology. So the adjuvant radiation therapy, as we said earlier, could be offered, but it should be given sequentially, starting with chemotherapy, followed by because of the proven survival benefit, to avoid the radiation-induced toxicity that could delay initiation of chemotherapy. There is no evidence to support a concurrent approach. Actually, there's some data that could suggest that it could worsen outcome. The positive margins in JCO, the positive margins, addition of adjuvant radiotherapy has shown positive margins based on JCO, a publication 2015, has shown a survival benefit regardless of the end status. The N2 disease and inadequate sampling of suspected mediastinal lymph node has been situation of controversy because of the conflicting evidence for additional radiation therapy, as we're going to see later. And the ANITA trial has shown inferior survival in 0 and N3 disease and improved survival in N2 setting, while a meta-analysis of 9 older trials has shown an adverse outcome, likely because of the higher doses of radiation and the older techniques associated with the risk of cardiotoxicity. There is an ongoing clinical trial, ERC-IFCT, that is trying to establish the benefit of adjuvant sequential radiation therapy in the N2 disease based on the ANITA trial. So here is a data supportive of adjuvant radiation therapy in incompletely resected to stage 2 and 3 disease, i.e. with patients with positive margins. Patients included had microscopic and macroscopic residual disease and different size, and they included tumor size, tumors larger than 3 centimeters. There was, as we said, survival benefit using the adjuvant radiation therapy compared to no radiation, and that was regardless of the N1 and status and the amount of residual disease, which was statistically significant, with a hazard ratio of 0.8 and of 0.67 in N0, 0.79 in N1, and 0.73 in N2 disease. So in the ANITA trial, as we said, they compare the stratified patients based on the N status, and N0 here you see the red line is for observation plus radiation therapy. The blue line is for chemotherapy plus radiation, the green for observation and chemo, and the purple for chemotherapy alone. We see that the addition of radiation therapy has had an adverse outcome with inferior survival, while in the N1 disease, the addition of radiation therapy to chemotherapy sequentially has been associated with an improvement in survival. In N3 disease, again, we see an adverse outcome with addition of radiation therapy sequentially to chemotherapy. This is here is enumeration of the data where the observation arm had 62 the 5-year survival for N0 disease. That observation was 62 with the addition of radiation 43, with chemotherapy 59.7. With the chemotherapy plus radiation therapy, the survival reduces to 44.4%. Similarly to N2 disease. However, in the N1 setting, there is an improvement from 56% with chemotherapy alone to 40% as there is improvement in the survival from sorry, there is improvement in survival in the N2 disease, and setting of N2 disease of by around 13% at 5 years. And the N2, while there is an adverse outcome, the N1 disease and N0. So how about having mediastinal N2 and N3 disease proven by mediastinoscopy and or ultrasound guided bronchoscopy? This needs to be discussed in the tumor board to review extension of the tumor and the nodal involvement, and to establish resectability of the tumor. Usually, there is a general single station N2 tumors of low volume, less than 3 centimeters, and have no contraindication of surgery. Patients could be surgical candidates based on the NCCN guidelines and based on the ISMO guidelines. Patients could be offered induction chemotherapy and current chemo radiation if we suspect that the resectability is not feasible because of the extent or the location of the tumor. There is limited evidence to support concurrent approach as it's not studied. There are multiple trials comparing URTs and comparing the concurrent chemo radiation and the induction chemotherapy with surgery, with or without surgery. And there was no difference in overall survival in three trials, despite the benefit that has been seen in phase 2 trials. The international OATH 139, ISPACHU 1, ORTC 08941 have also been in concordance with in terms of having no survival benefit from surgery. However, in sub-analysis, as we're going to see later, the N2 disease, single station N2 disease, have achieved survival benefit has made it an acceptable situation which the patients could be offered surgery. Pneumonectomy is considered a requirement, is considered a contraindication because of the high mortality rate, while we have no strong evidence to support the surgery in this setting. However, if you had a T4 disease that was extending to surrounding structures and multistation N2 and N3 disease, as per guidelines, this is situation where you should offer the patients definitive concurrent chemo radiation, and surgery is not typically offered. The patients who are considered unfit because of comorbidities, the concurrent approach could be associated with unacceptable toxicity, and therefore sequential chemo radiation or radiation alone is an acceptable alternative. In al. in 2004 have shown that the survival outcome at 3 and 5 years, improving from based on the single N2 status compared to multiple station N2 disease after complete resection. That comes in accordance with other data, and therefore in single station N2 has been a situation where we can move on with surgery if complete resectability has been considered possible. Now, in the 1990s, we had to discuss the role of radiation therapy in N2 and N3 disease. In the 1990s, we had 5 randomized trials showing improvement in survival with chemo radiation compared to radiation therapy alone. A sequential approach has been has been followed, and concurrent application of radiation therapy has been avoided to avoid overlapping toxicity. The median survival has been noted across the different trials to improve from 12 to 14 months compared to 9 to 12 months with radiation therapy alone. There has been variability in the treatment regimens, the dosage, the dose, and the schedule and the timing of radiation therapy. The phase 2, then there has been subsequently there has been phase 2 trials examining the the feasibility of concurrent chemoradiation, and has been shown to be an acceptable approach with limited toxicity, with acceptable toxicity, and with survival improvement of approaching 16 to 20 months. The reference for the concurrent chemoradiation approach that has been adapted by different guidelines, it comes from the RTOG, basically from the RTOG 9410 phase 3 trials that count 3 arms. A phase 3 trial that had that compared 3 arms. The first arm, they had vinblastine weekly for first 5 weeks with plus cisplatin from day 1 to day 29, and then followed by radiation therapy alone. And the vinblastine arm, they had, the arm 2, they had vinblastine plus cisplatin, followed by concurrently with radiation therapy. And arm 3, they had oral etoposide, 50 milligrams, plus radiation therapy twice a day, and combination with cisplatin. And the 5-year survival for comparing the arm 1 with arm 2, i.e. the sequential with the concurrent arm of radiation therapy, has shown an absolute improvement of 6% with hazard ratio of 0.812, while there was no statistical significance in survival, no statistical significant difference in survival when comparing and once with twice daily dosage of radiation. That comes with an association that comes in conjunction with the high rate of toxicity with the twice daily dosing. There were different regimens that have been adapted for based on phase 2 trials for concurrent chemoradiation. The cisplatin gemcitabine has been abandoned recently because of increased rate of pulmonary toxicity, while we have more tolerable regimens. The multi-agent regimen used in the Japanese trial has also been abandoned because of high hematological toxicity. Preferably, we can use cisplatin plus vinorelbine or cisplatin plus etoposide, weekly paclitaxel plus carboplatin, followed by 2 cycles of docetaxel. In the Proclaim trial has also offered Pimatrix and platinum, followed by maintenance Pimatrix for 4 cycles as another option. However, my preference is cisplatin etoposide because it can be given concurrently and with no need for consolidation therapy, and with acceptable toxicity. There has been a comparison between cisplatin etoposide and weekly paclitaxel with comparable survival benefit and all response rate. While etoposide was stated with increased risk of esophagitis, the paclitaxel was stated with increased risk of pneumotoxicity. There has been different, the introduction of Pimatrix has been, in combination with cisplatin, has been thought to be associated with an improvement on in response rate based on the stage 4 disease data, but actually comparing Pimatrix with cisplatin to etoposide cisplatin, and has shown no difference in survival benefit, with 26 months with overall median overall survival approaching 26.8 months in the Pimatrix cisplatin arm and 25 months in etoposide cisplatin, while we that's despite the consolidative phase of that has been additive to the Pimatrix cisplatin regimen. So a meta-analysis in 2006 was published comparing different regimens, and the survival benefit of concurrent chemoradiation remained standing compared to radiation therapy alone, and approaching 2 years, the survival approached 25% at 2 years compared in concurrent arm compared to 21 in the radiation arm alone. And the 5-year survival has also been improved to 8% compared to 6% in the radiation therapy arm alone. And as we see, the median progression-free survival remains limited at 11 months. So the median overall survival is only around 2 years. And meta-analysis by 2010 by Auburn et al. And JCL showed a 5-year survival approaching of 15% as at maximum. Therefore, multiple approaches have been examined to improve the survival in stage 3 disease. One of our approach was the examining the consultative and addition of oxidative phase after chemotherapy. This has shown no survival benefit in the GILT trial. The dose of has also been tried and by Bradley et al. And colleagues, and this has shown an inferior survival compared to standard radiation dose of 60 grays. The addition of cetuximab has shown no survival benefit compared to standard of care alone following radiation therapy, chemoradiation therapy. So, but lately we had an interesting addition to the management of stage 3 disease following concurrent chemoradiation, which is maintenance immunotherapy. Radiotherapy has been over the 5 decades an interesting has shown an interesting phenomenon of abscopal effect, where targeting radiation targeting one lesion with radiation therapy could lead to response in other lesions, and this has been assumed to be related to radiation-induced immune response, and that was supported by the benefit of checkpoint inhibitors and immunotherapy later in melanoma patients. The assumed mechanism for benefit of the positive interaction between radiotherapy and immunotherapy has been related to upregulation of MC class 1 secondary to radiotherapy on co-stimulatory molecules, and new antigen increase in new antigen expression, cancerous cells, and suppression of immune inhibitory T cells like Tregs and dendritic cell maturation cells. The radiation has also been hypothesized to improve vascular permeability, increasing the drug delivery to the tumor microenvironment. However, the timing of administration should be taken in consideration because of the duration of expression of the antigens and the co-stimulatory molecules, and the other tumor microenvironment effects. It's transient, and the keynote, the interest in addition of immunotherapy came from the keynote 001, where the stage 4 disease, where previous exposure to radiation therapy conferred an improved progression survival and overall survival with pembrolizumab. And therefore, the Pacific study came out showing and examining the maintenance, the effect of maintenance durvalumab following concurrent chemoradiation compared to placebo in 713 patients, following randomization mode of 2:1. The patients were randomized to receive immunotherapy at 1 to 42 days after ending radiation therapy, and this is an important point. Only the responders were included in this trial following from concurrent chemoradiation based on imaging within the first 2 weeks of ending radiation. They included stage 3A, unresectable stage 3A, stage 3 disease, good performance patients, squamous and non-squamous histology, smokers and non-smokers. Most of the patients received a standard dose of radiation, 54 to 66 grays, and a majority of the patients had the chemotherapy concurrently with the radiation therapy. The induction therapy induction chemotherapy has been used in 25% of the patients. That's an indication that we're going to talk about later to improve the radiation field to an acceptable limit for concurrent chemoradiation. As we see here, the progression-free survival with addition of durvalumab has been remarkably increased to 16.8% compared to 16.8 months, sorry, compared to 5.6 months. This has been noted at 12-month cutoff point and at 18-month cutoff point. With hazard ratio of reduction of death at 0.52. The survival, the progression, the benefit has been seen across and sub-analysis across different subgroups, regardless of the PD-L1 status, and smokers and non-smokers, because we know that smokers have a high mutational burden that confers high responsiveness to radiation therapy. But we have seen the benefit also in non-smokers. The side effects were tolerable, consisting of pneumonitis, of radiation-induced immune-related. They were majorly immune-related, including hypothyroidism and fatigue and pneumonitis. The further analysis of the data to look for overall survival has also been published in New England Journal of Medicine in 2018, and therefore this has the maintenance immunotherapy has become the standard of care based on improvement in an unprecedented improvement in survival, which has not been reached compared to 25 months follow-up period, compared to 28 months in the placebo arm. There are different approaches that are being evaluated currently in ongoing trials, incorporating immunotherapy into the treatment regimen, where adjuvantly after a complete resection and concurrently with radiation therapy, using different chemotherapy regimens, and using different immunotherapeutic agents, atezolizumab and pembrolizumab and nivolumab. The new adjuvant chemoimmunotherapy, this is a small, this is a phase multi-center exploratory phase 2 trial incorporating chemo with immunotherapy in a new adjuvant setting, showing a partial response of 72% and complete response of 6.5%, which has been interesting. And we're awaiting these results to see if it could be practice changing. This is the incorporation of immunotherapy continues in adjuvant setting using nivolumab. As we said, that the tumor board is an essential essential step to in a collaborative group to achieve the best therapeutic approach. Helen Powell and colleague has published an suggested pathway for confirmed or suspected thoracic malignancy, consisting of the diagnostic phase and therapeutic phase, where starting from where the patient comes from GP to the respiratory clinic, and then undergoing diagnosis, and then being presented in the multidisciplinary team and they're referred to treating specialist with an established follow-up plan and treatment plan in the multidisciplinary team. They have also recommended a multidisciplinary team report to be documented and to be available to all healthcare professionals, including the demographic data of the patient, the stage, the treatment, and the follow-up plan, whether a majority or an anonymous group have agreed on the decisions, and to include the reasons for not following or adhering to guidelines and recommendations, general recommendations. The advantages of the multidisciplinary team, they have also detailed the advantages and disadvantages of the multidisciplinary team, where patients could benefit from a group, and as an advantage, group decision. Clinicians will have a particular time to complete the discussion, and opportunity to educate and to have high standard service with the backup plan, but as a disadvantage that could pose delay if information or investigations were incomplete. And the time required for the meeting could take from the clinical practice of the clinicians, with potential conflicts and opinions. So in conclusion, it's essential to have a multidisciplinary team to establish resectability of the tumor and to determine the best therapeutic approach and management plan and follow-up plan for the patient. The therapy and prognosis. The therapeutic approach for advanced stage disease remains controversial with particularly in terms of surgical management for subset of patients of T4 and stage 3 BTT disease. For stage 3A, it has been determined that the standard approach and most recommended for improving during prognosis is surgery followed by adjuvant chemotherapy. However, in stage 3B disease, we can identify patients as having single station N2 or multi-station N2 and 3. For in single station N2, we can go for section direct if the patient that was feasible with an RZ was suspected to be feasible. Or to go for induction concurrent chemoradiation followed by surgery. For multi-station N2 or N3, it's in the concurrent chemoradiation is the standard approach right now, to be followed by maintenance immunotherapy as per NCCN guidelines. The resectability has been defined in both ISMO 2015 and NCCN 2018 as having minimal non-bulky N2, single station N2, low volume lymph nodes, pathologically proven lymph nodes, or a measuring with the tumor with the low volume tumor measuring less than 3 centimeter. Following the approaches that we have mentioned earlier. The pneumonectomy requirement because of the high mortality and having medically unfit patient, the N2 disease with extracapsular extension, multi-station N2 are all considered contraindication for surgery at this point. As per guidelines, the concurrent chemoradiation followed by maintenance immunotherapy has shown to improve survival benefit recently and has been adapted as standard of care. In this condition, there are questions have been raised about the benefit of surgery for following chemoradiation, because the patient may lose the benefit of immunotherapy as the data analysis has shown that the maximum benefit is achieved when you introduce immunotherapy within the first 2 weeks after the ending radiation through concurrent chemoradiation. As we have seen, there are ongoing trials to incorporate immunotherapy and therapeutic approach of stage 3 disease, and they're waited to see if it could be practice changing. Thank you so much. Hello?
Thank you, Dr. Munera. It was a great comprehensive review. Would like to ask Dr. Swalem to comment or make questions if he likes. Dr. Swalem, you're unmuted.
Yeah, thank you, Dr. Munera. Excellent. Very comprehensive about talking about stages 1 up to 3. From a thoracic point of view, we always tend to, of course, find the best operative procedure for patients. And as we know, surgery is a cornerstone for any better outcome. Most of the time, unfortunately, we all know that most of the lung cancers are presented late stage, around less than 20% are resectable. My question to Dr. Munera, what about stage 3A with mediastinal lymph nodes and staging confirmed positive lymph nodes, chemoradiation induction was given? Do we need to go for restaging, or we should go for surgery immediately?
I think restaging to see how the treatment, if we had achieved the overall response rate that made the patient, the R0 resection feasible.
Yeah, for especially for I mean, the important thing is to make sure our N2s are negative, and we tend to initially do a mediastinoscopy for these patients to confirm the pathological diagnosis of mediastinal lymph nodes. Once they're positive, they go for induction chemotherapy for possible surgery, regardless of let's say it's an early stage T, but the lymph nodes are positive. Then we restage them again and confirm that the lymph nodes are responsive, and then we can go for surgery. From a thoracic point of view, restaging the mediastinum is technically demanding. We have other options to do it, including going with EBUS with the help of our fellow pulmonologist, and also we can go for a diagnostic thoracoscopy. But it's very crucial to rule out N2 because the outcome differ.
Okay.
Any questions?
I probably would ask about, you know, we got a couple of studies, comparative of results from all over the world. Probably Dr. Munera goes over the UK population, and I wonder if we have in Saudi Arabia as similar or comparative studies to such, I mean, disease.
No, actually, I'm writing commentary for Saudi Medical Journal about the patients for research. I think that collaborative work is needed, and there is lots of area for research, especially on stage 3 disease, to be honest. I think we could start with retrospective analysis, looking at the outcome of the period, different subgroup analysis, to see the prognostic factors. And from there, we can make a hypothesis-driven exploration.
As you know, what I was asking, because we really got a major you know, registry of tumors in general Saudi Arabia, and probably it was led by King Faisal a specialist hospital research center for major you know, tumors in Saudi Arabia. But you know, I don't think at current late years we got such, you know, collaborative data collection from all centers, as we are growing in highly specialized centers all over the kingdom. Basically, if you go, for example, take example as Riyadh, we got many centers that treat cancers, and not only the data was collected earlier stage by King Faisal. I believe you are right, this should be done in collaborative study. One point probably in Prince Sultan Medical Military City, that the radiotherapy and is probably a huge part of the treatment, as you presented. I guess we got in Prince Sultan probably more data other than compared to other centers. I mean,
Could you unmute kindly Dr. Fawaz Al-Harbi?
Dr. Fawaz, he is in. Dr. Fawaz, can you raise hand so I can identify you? I don't see him.
Okay.
Unless he is out, I'm not sure. But I can't see him.
No problem.
All right. So back to the question. So do you think that Prince Sultan, as by chance, that probably we got more on the radiotherapy rather than other centers, and in probably in Riyadh, as we grow, in a couple of centers that treat cancer patients, that we have to update our data in Saudi Arabia? I don't know, Dr. Mira, do you hear me?
Yes, I hear you.
Yeah.
So I think that for accessible and to draw more accurate conclusions, especially at this representation, in this situation of representation, that that requires data from as many centers as possible. As we have seen, most of the trial have been broadly has included data from 186 centers, and also centers were across Europe and Canada. The trial as well has included multiple centers to show the prognostic effectiveness of CTC disease. So collecting as the largest number possible is an essential to power the study to draw more accurate conclusion. To make a sub-analysis, it's based on unsuspected stratification.
Dr. Mira, if you can access the questions, because you got 3 questions from Dr. Hatem, I think Hatem Nasser. You can access it from your side and answer.
Do you think that new immunotherapy agents are going to replace the conventional chemotherapy in treatment of non-small cell cancer? Chemotherapy, cyclophosphamide and platinum have shown to improve the immunogenicity of the tumor and to responsiveness of the immunotherapy. I mean, we have seen that in stage 4 disease, where a single agent pembrolizumab has been approved as a first line therapy in high PD-L1 expressing tumors. So this is possible, to be honest, and but I mean we can use for instead of combination single agent therapy to improve the toxicity and profile, or we can replace totally with immunotherapy. That depends on what we're going to see in subsequent publications. What is the recommended time interval following radiochemotherapy for restaging? It's around, I mean, it should be done immediately and to introduce immunotherapy as we have seen within the first 6 weeks, where the most benefit is seen in terms of introducing immunotherapy in the first 2 weeks. Should be done immediately, to be honest. Do you depend on, as per recommendations, do you depend on CT scan only for staging, or there is other adjunct procedures or imaging modalities do you recommend? As CT is enough, PET scan could take longer for it to arrange, but CT has been enough, and as per the Pacific trial.
I'd like to answer the last question as well.
Okay.
Yes, go ahead, please.
Yeah, regarding the CT for restaging, we just had a recent case referred to me by Dr. Munera. It was a radiological possible T3 or M1. There was pleural effusion and contralateral mediastinal lymph node. Now, for like I said, mediastinum is also a crucial part of staging. So we did a mediastinoscopy and we did a pleural biopsy thoracoscopy to confirm a pathological staging. And alhamdulillah, it became all negative. So the patient was fit for a surgery and he underwent a sleeve lobectomy yesterday. I'm sorry to say, like I said, the problem with our regional population, I believe strongly in screening in these stages, and probably that will increase the number of volume, and we can have a thoracic input in these cases. Most of the cases I've seen are either late stages or inoperable. So I think the crucial part is screening so we can have more volume and we can conduct our own studies.
So, Dr. Sweden, do you think we should make a collaborative work with the family physicians to stimulate the screening for smokers and facilitate the referral within an acceptable period?
It's been conducted on a regional level. Some hospitals and some private hospitals are doing that. We've had our individual relationship with radiology, and I've been doing most of the legwork and finding incidental lymph nodes that were missed for from other reasons. But yes, I believe we can collaborate on with family physicians and pulmonologists for any patients with incidental findings of pulmonary nodules to be enrolled, and that will increase our volume.
I'm sorry, what is the national program status in this?
You mean in terms of recommendations?
I mean the Saudi program for cancer screening in general. As we know that we have some active programs tend to, medical and, supportive programs. So what is the status probably in lung cancer?
I will leave this to Dr. Sweden. I'm not sure, to be honest.
Internationally, the recommendation is to do a high resolution CT for smokers above 45 to 50 for incidental pulmonary nodules. The problem is it's not implemented here exactly.
What about the, part of good screening is education. I know the government has done a lot of efforts, basically in smoking restrictions, and matter of changing regulations, putting more strict way of purchasing, increase the price, and those blah blah blah. But what about the education of population? That what I feel. At one stage, we got a huge educational and community-based, broadcasting for tumors and cancers. But is it still active in a good, positive way, or it is like, just control on purchasing and marketing and those things?
I think the government did very well in controlling purchasing and advertisement around the risk of smoking. Of course, we know we have a young population, and lung cancer is a disease of middle-aged and elderly populations. So I'm sure all of us, when we did our fellowship outside, we would see a lot of patients. Here, the issues are still a young population. Screening is mandatory to pick up early lung cancers, and government help and hospital help in education and screening those who are highly risk will increase our volume. But at the end, it's a calibration from government, hospital, individuals.
Super. Is there any biomarkers that could be used, as mass screening?
Smoking. So for the approved screenings that has been recommended for smokers.
But they should go for CT, spiral high-speed CT, right? I mean, is there any other like biomarkers, blood tests, or other things that can go for biomarkers and genetic analysis?
Not if you said I mean, I'm not aware of any biomarker that increases susceptibility for cancers other than the smoking to initiate screening tests. The family there are family clusters of lung cancer, but this is very, very rare. It's not amongst the hereditary diseases for which we initiate screening programs like in breast cancer and ovarian cancer.
Super.
There's no specific biomarker for lung cancer, specifically for lung cancer. Like if we compare CA for colon cancer as a screening or follow-up assessment, but in lung cancer, no, it's unfortunately it's not. Yes, those are high risks to go for resolution, high CT, but there's this very, very small proportion of patients with paraneoplastic symptoms, and they present with other parameters that can be picked up, and those are incidentally picked up with having a paraneoplastic lung cancer, which is also very rare.
Super.
So to answer your question, there's no specific CA19-9 was suggested, but not specific for lung cancer. I believe screening would be, like Dr. Munera said, would be the best option for these patients.
Super. I hope this will be like, you know, supported by Saudi Council for Health and as other, you know, motives has been done. Because obviously, as I understand from the lecture, from the discussion, that we are really getting cases somehow late and needs really active screening. All right, I would like to thank Dr. Munera for her comprehensive lecture. I would like to thank also Dr. Suleiman for his moderation and comments. I would like to ask our attendees for their time and joining with us the lecture. Thanks a lot. And I would like to ask you please to go over the evaluation form that you will get immediately after you leave the meeting. Thanks a lot. Thank you, Dr. Munera. Thank you, Dr. Suleiman.
Thanks, Doctor.
You're welcome anytime.
السلام عليكم. السلام عليكم في أمان الله.